Hello, everyone, and welcome to the State of Health and Wellness Media Breakfast. I'm Takia Smith, and as always, I'm glad you could join us today. The Ministry of Health and Wellness has been at the forefront of COVID-19 management and has also been working on a number of developments to strengthen the Cayman Islands public health infrastructure. Here today, we have our panelists. The first, the Honorable Sabrina Turner, Minister for Health and Wellness. Our Chief Officer for the Ministry of Health and Wellness, Ms. Nellie Pucci. Our Interim Chief Medical Officer, Dr. Artilia Newton. Also in studio with us, we have our National Epidemiologist, Ms. Rachel Corbett. Joining us today, we have key ministry stakeholders and our media partners. Without further ado, I'd like to hand it over to the Honorable Minister.
Good morning and welcome to the first State of Health and Wellness Media Breakfast. It is a pleasure to be here with you, and we have invited you, our local press, here today to share key developments from the Ministry of Health and Wellness. Now, as you all are aware, the COVID-19 pandemic has dominated our thoughts, conversations, as well as the airwaves and social media channels for the past 2 years. Now, while the pandemic is by no means over, for the past few months, we have been transitioning our efforts towards equipping our population to living safely and mindfully with COVID. Now, while the demands created by COVID-19 have been many, the holistic work of the Ministry of Health and Wellness and the numerous departments and statutory authorities that fall within my ministry's remit has not stopped. As such, today will mark a change in the way that we share information with our community. Now, the pandemic continues to teach us lessons, and as the ministry, we are committed to learning from the experiences to address gaps, enhance services, and definitely to continue to build resilience at the individual, community, and national level. One of the key lessons learned has been the need to strengthen public health nationally. It is imperative to note that when we speak of public health, we are not referring to a department, but to rather the specific science of protecting, promoting, improving the lives, health, and wellness of families, communities via prevention, education, access, and personal empowerment. As such, I am delighted today to confirm that Cabinet has approved in principle for the ministry to develop a business case to reform public health at the national level, that this would include public health being separated from the HSA as we know it. Now, the development of this business case is the first in what will become a series of tangible steps that will engage our stakeholders in the process of achieving this very same goal. Public health extends far, far, far beyond preventing the spread of communicable diseases like COVID-19, the flu, and even monkeypox. Public health is also concerned with being proactive about prevention of non-communicable diseases such as heart disease, cancer, and diabetes alike. Now, these diseases have also consistently had a significant impact in our community, to which many of us, I'm sure, can attest based on personal experience or those of close family and our dear friends. Mental health, which has also been highlighted as a key concern of this pandemic, is also a public health issue, and one that the country has agreed warrants much more attention, especially as it relates to our youth. The National Drug Council has been doing an exceptional work with their student drug use survey since 1998. And over the years, this tool has expanded to help capture more holistic and vital information directly from our very own young people. Now, preliminary results for the 2022 NDC survey identifies key ACEs, or adverse childhood experiences, which research has shown can change brain development, affect how the body responds to stress, and are directly linked to chronic health problems, mental illness, and substance misuse in adulthood. Among the key ACEs identified in this year's survey, let me highlight some of the following information, which I'm quite sure you'll find alarming. Almost 8 in 10 students, 79.7%, reported that they had witnessed violence and aggression. 43% of students reported experiencing any abuse. Of those, 50% equated to girls and 36% to boys. 52.4% of the respondents reported being bullied at some point in time, of which significantly more respondents were girls, 60.3%, compared to our boys of 44.1%. In 1 in 8 students, or 12.5%, stated that they had attacked someone with intentions of serious harm. Now, the survey also provides us with key insights that may be, as I stated earlier, a bit difficult to digest. But this vital information is able to us determining an effective response. An effective response, I mean, the scoring of the responses indicates that students alone from Bordentown and Northside experience a higher level of adversity than those in Georgetown and West Bay. As it pertains to students attacking others with intention of serious harm, the research were able to compile a list of predictors of students who may have attempted such attack, forced not only on previous behaviors, but also the year groups were more likely to engage in this type of behavior. Now, while these are only some preliminary findings of the 2022 NDC survey, the full report will be released later this year. I find it very important to highlight this information to emphasize the importance of data, the collection of data, and how we as a ministry have started working to ensure that future programs, services, and intervention are data-driven. Now, this morning, you will hear from my team on key developments and the changes. I ask that you keep in mind that all the work that has been done has been with the goal of strengthening our public health nationally. An example of our work includes a significant win for our country. Recently, the Cayman Islands has become the first United Kingdom overseas territory in the Caribbean to request the extension of the World Health Organization's Framework Convention on Tobacco Control legislation to our country. Now, this convention is an evidence-based treaty that addresses another global pandemic that claims 7 million lives every year. That's tobacco. While our interim CMO will be addressing this convention and its impact in greater dealings with during her presentation, I am happy and proud to say that this legal framework will allow us to develop and expand more comprehensive approach to tobacco control that will pay dividends in strengthening the health and wellness of our population. I would like to thank all of you for being here today and for your assistance in keeping our people informed. I will now hand over to my team, who will outline and elaborate on various existing and forthcoming initiatives and undertakings that support our overall goal in strengthening public health nationally. It is my pleasure to hand over to my Chief Officer, Nellie Pucci, for her presentation.
Thank you, Honourable Minister. And good morning, all. Thank you again for joining us today. I'm very pleased to be able to update everyone with respect to 3 key positions within our ministry today. Minister spoke a bit about the ministry embarking on a new direction, which requires us to be more data-driven. And in that vein, we are pleased to announce our national epidemiologist, Ms. Rachel Corbett. Rachel has joined our ministry on a temporary basis to help us to develop some of the key aspects of epidemiology in the Cayman Islands and with respect to our own data. And we're very pleased to have Rachel on board with us. Just a little bit of a background in respect to Rachel. Rachel has worked as an epidemiologist in the UK with experience at the local, national and international level. Rachel previously studied at the London School of Hygiene and Tropical Medicine and completed the highly regarded UK Field Epidemiology Training Program. She's worked across many different surveillance systems. And during the pandemic, Rachel led the International Travel Risk Assessment Team within the UK COVID-19 incident response to assess the risk of COVID-19 travelers and what they faced when visiting any country in the world, which helped to inform government policy. The ministry is most pleased to have Rachel on board, and you'll hear more from Rachel as we move along. Additionally, I'm also very pleased to welcome and to announce our ministry's communications manager, Ms. Carolina Ferreira. Carolina is a new addition, just joining us within the past week, so she's brand new for us. However, she's already hit the ground running. This is a key position in our ministry. We've been lacking in that regard for some time, so I'm very, very pleased to have Carolina on board. Carolina is not really a stranger to the local community, as she has spent a lot of time in various partnerships with key NGOs, private and public sector stakeholders. Most people will know her in her role at the Red Cross, but just to give a bit of a little blurb, a background on Carolina, Ms. Carolina Ferreira has 25 years of experience in working in the field of health, human and humanitarian services. She has joined us from the Red Cross, where she served as the organization's deputy director, as well as its Child Protection and Sexuality Education Program Manager. Ms. Ferreira holds professional certifications in strategic health communications from Johns Hopkins University and sexuality education from Planned Parenthood. We are very pleased, as I say, to have Carolina on board, and welcome again, Carolina. Finally, with respect to another key position which we have at our ministry that I'd like to announce today is that of the incoming Chief Medical Officer. So the ministry is very pleased to announce that Dr. Nick Gent, CBE, will be joining us as our Chief Medical Officer as of the 3rd of October 2022. Dr. Gent is a highly reputable physician who holds over 20 years of public health experience, including his most recent post as Senior Medical Advisor and Consultant in Public Health with the UK Health Security Agency. He's also worked as Director of Public Health in a number of district public health services and served as an executive member for multiple health service authorities within the UK National Health Service, with responsibility for public health, health protection, and commissioning a wide range of healthcare services. In addition to his work as a senior public health official, Dr. Gent has worked with global bodies such as the European Union, World Health Organization, and the World Bank, where he advised on legislation concerning public health, human rights, health regulations, and other matters. The ministry looks forward to working with Dr. Gent, and we will keep you posted as to when he actually arrives. Arrives on island. He's expected to join us on the 3rd of October. Before I move on, I just want to also pay thanks to our current interim CMO, Dr. Ottilia Newton, who has been with us from the inception of the pandemic in various different roles, and her experience has seen us through to this period. So even from when Dr. Lee was here, Dr. Newton would have been advising from a different aspect. So I want to thank you, CMO, for your work to date in that regard. So I'll have more staffing updates to be able to share as we move along. As Minister mentioned, we are in a different direction, that we're looking to be more data-driven, so I would want for that aspect to be highlighted a bit more today. That's very important for us, that we know what our own numbers are and how best to make decisions that are very relevant for us. So I'll leave it there for now and ask CMO, invite her to join in.
Thank you very much, Honourable Minister and CEO, members of the media and the public hall. It is a big privilege for me to be here today and to put a bit of more details on what has already been outlined before. So I have chosen to go into three matters. One is to do with COVID and the imminent autumn campaign and the vaccine. The other one is very briefly on the monkeypox, and then the last one is a few more details on the International Convention for the Tobacco Control and the passing of the legislation. So let's get on first of all with COVID. So is the first topic. I've got a very, very brief presentation. It's only 2 slides, basically, not 3 slides. So that's the first one. So to understand COVID, I thought that we could have really a few bullet points to say where we started and where we are now. So we started in 2020. We know now that actually maybe the first cases were in 2019. This is worldwide, but it's 2020. And then we were facing a virus which was completely new. So completely new, it means that nobody in the world had any protection, any antibody, any defense against this virus. And this is then, it became very, very quickly clear how transmissible it was and how lethal it could be. And you know what we have gone through and so on. So it's quite, it was a real emergency. This is why it was declared as a pandemic. Now, from there, we are now with vaccines have been developed. And because the virus is new, so it keeps mutating. This is why we have all these variants coming up. At some points, one variant then becomes predominant and throws the others out. So there is circulation of the virus, which continues, which means that people are exposed, and then there is this combination of natural immunity, which comes from the exposure, plus the vaccine, and therefore the change in response of the host has changed. So we are in a much, much better place than we were in 2020. So that's the first point. So we moved from trying to suppress and contain the virus to now living with COVID. And we can do that because most of our population has got immunity now, some sort of protection against the disease, or at least against the most dangerous forms of the disease. So we've been monitoring COVID in a slightly different way. What are we going to look at are our key indicators will be the hospital admissions and deaths, because that is very tangible. We're very sure of those figures, and therefore that's what we are going to monitor. It means that if things change, then we can respond very, very quickly. We will be collecting other information, of course, coming from the laboratories in terms of how many people are testing positive, etc. But we know that now the number of PCR results we give you are not fully representative of how much virus is around. And our priority, as I say, it is now to simply check that we are sure that there is not a lot of people ending up in hospital or people dying. So this is therefore our key indicator. This is the columns in greens are the hospital admissions, where there is a recorded test positive for COVID. Now, some of them will be people who are there genuinely because the COVID has caused the problem. Some others is more an incidental finding because people are screened when they get to hospital, but in fact they are there maybe to deliver a baby or something like that. However, we do keep an eye on everything. What is very important is also the number of deaths. Now, Cayman is really in a very, very lucky position in the Caribbean because we, thank goodness, we still have a very low number of deaths, which if you then look at these last slides and you look at what has happened in the Caribbean, you can see how low down we are there. And our surveillance is very precise in terms of number of people who have died with COVID and so on. This is the number of deaths which has then been standardized for 1 million population. And so looking at these two things, that now we are confident enough, if we keep up our vaccination program, that we can afford to take away the control measures, or many of the control measures, which have been in place so far. This is why the repeal of the legislation, which was announced last week. Which brings me to the next point, that is the one with the vaccination. So, there has been a huge international effort to produce vaccine against COVID. Because against infectious diseases, especially if you are talking viruses, treatment is usually not very easy, straightforward. The best thing you can do is vaccine. So development of vaccines which have become more and more targeted, more and more specific, has been absolutely fantastic. Many people might have heard about the latest arrivals, which are the Moderna vaccine, which doesn't have just the original Wuhan strain, but's got also one of the Omicron variant in it. And this vaccine has shown to be marginally better compared to the Pfizer and the AstraZeneca with just the original strain in preventing the severe disease and death, and preventing also infection with that particular subvariant, which is the BA1. So we are expecting the delivery from the UK government of the next batch of vaccine. We have asked for some Moderna, we have asked for some Pfizer, which will mean that we can do then our autumn campaign, which is targeted mostly at people above the age of 50, and then anybody from 5 to 49, which is in at-risk groups, etc. We can continue to use the Pfizer. We still have Pfizer with the original strain. We can use that, so we don't have to stop the campaign, the booster campaign, or if people haven't had their primary course. But with the arrival of the Moderna, as soon as it arrives, then we can start using that one as a booster. The original Pfizer is absolutely fine, and it's most important that we ensure that people get the booster rather than trying to wait, for this Moderna, etc. So we don't want to interrupt the campaign. If we keep up our vaccination, we are in a good state to control severe disease and deaths. So that's the message to encourage people to come forward for their booster. Then let me just close on the surveillance for COVID. As I said, we will keep monitoring those key elements of hospital admission and deaths. We will keep collecting the information on testing, etc. There is also the fact that COVID is going to be monitored alongside other respiratory viruses, such as influenza or respiratory syncytial virus, etc. And this is through syndromic surveillance and then testing of subset of positive samples to sequence these viruses and see what is circulating. As far as COVID is concerned, it's still extremely important that if people have got symptoms and they can do an LFT and the LFT comes positive, please do the PCR to confirm it, because then we can also see which variant is circulating. And it's very important to do it at the beginning when there is more virus around that, so the genome sequencing has more chances of being successful. So the other things I would like to mention is the monkeypox situation. I've had some members of the public or colleagues very concerned and saying, is going to be another COVID situation. Well, let me reassure you, we are talking of completely different viruses here. Yes, with monkeypox, there is a possibility of some air transmission, but that is very limited compared to the close contact transmission. So two things. Last week has been the first time where the monkeypox cases are starting slowing down in the USA, which is now the country where there are most of the registering most of the cases, which is a good news. What we here in Cayman, we still have got no confirmed case of monkeypox, and we are confident about that because we can diagnose locally. We do not have to send our samples to regional laboratories, which then takes a long time to get the response. We can have the response within hours, which is the first line of defense against any infectious disease of significant public health relevance. We are doing, we continue to do preparatory work, and we did some training for all GP practices and for A&E consultants to explain about, to refresh them about symptoms and signs, how to recognize it, what to do, who to call, etc. We now want to have a meeting, a multi-agency meeting, to think in terms of how we approach and sensitize and target group groups and activities which are relevant to the transmission of monkeypox. Monkeypox can infect anybody. It's very much skin-to-skin contact. So you need to look at a lot of things. And so we are planning this meeting, and there is work has gone on to prepare detailed information, both for the health workers and for the public, in terms of a leaflet, which explains very, very simple, in simple terms, what you can do, what you cannot do. As you know, there isn't a specific vaccine for monkeypox, but the smallpox vaccine is quite effective in protecting people. However, it is in very short supplies, is quite difficult to get hold of it. So we are doing all this preparatory work because we are then going to hopefully negotiate with the UK government to get some supplies here once we demonstrate that we have a plan on how we want to use the vaccine. Mm-hmm. And then let me come to the last point before I pass on to my colleague Rachel, which is that one the Minister has already mentioned, of the passing of the legislation of the FTCT, which is the control tobacco regulations. So this is a WHO international framework that the UK government is a signatory for, and so they have been implementing it since many years. The UCOTS, because of their links with the UK, are therefore invited or asked whether they want to ask for the extension of this legislation to their own territory. And I am extremely proud, as Minister has already mentioned, and she's herself, that this government has managed to say, yes, we are ready and we want to have the extension of the legislation here in the Cayman, because they are ready for it. You see, it's not a simple thing to say, oh, yes, yeah, we say yes to the legislation. No, that implies modification of your tobacco law. And all this work has already been done. Mm-hmm. You know already that here in Cayman it's not possible to smoke in public buildings, for example, or on public transports. This is the effect of the 2008 tobacco law, which then was reviewed in 2010. So a lot of work went into that. Plus is the pricing of the tobacco, the health warning, the services that you have to encourage people to stop smoking. As far as we know regarding the prevalence of smoking in Cayman, the data we have are now the one from the SEP survey, which was carried out in 2012, which showed that more than 16% of the population was sampled at the time was smokers, but that goes then up to 20% when you're talking men. So there is work to do. Yeah. We very much ready. Cabinet has done something absolutely fantastic. We are the first UCOT in the Caribbean and only the second UCOT amongst all the 12 across the board to ask for the extension of this legislation, because there is enough work has been done to be able to ask for that. There is more work that will come, that is something that is so important to protect the health of our residents here in Cayman. So thank you very much for allowing me to give you this update, and I'll pass now on to my colleague, Rachel.
Good morning. Thank you, CMO, Honorary Minister and CEO, and the public media. It's a privilege to be speaking to you this morning, and I'm going to be outlining some of the public health surveillance work that we have in development and forthcoming. Public health surveillance of infectious diseases like COVID-19 and also non-infectious or non-communicable diseases is essential for us to understand the public health needs in the population and to determine the best approaches for prevention and for treatment. As has been described by the Honourary Minister, we need to gather, to analyse and to report public health data to be able to make evidence-based decisions. At its core, public health surveillance is about providing information for action. And currently there has been relatively limited public health data available in the Cayman Islands to understand the burden that there is in the population, and we're very much looking to develop and to strengthen that. Understanding the epidemiology of non-communicable diseases, for example, diabetes, hypertension, or obesity, is a high priority, and we're looking to do this in a number of ways. Recently, the census report was released, and there was a question in it which focused on, particularly on disability, and had a question about medically diagnosed illnesses in the population. And what it reported was that the highest occurrence illnesses were diabetes, arthritis, and cataracts in the population. The census is a really helpful recent source of information about the population. And it's particularly helpful for public health data because it provides a denominator of the size of the population, but also the population according to different age groups or different demographics. And we can use that when we have other health data to understand the rate and the prevalence in the population and to be able to compare this to other population sizes. It was also very beneficial to have this question about disability and illness in the census to understand in part some of the burden that there is in the population. However, compared to with other data sources as well, we do need to consider what the limitations or the caveats are to know how to consider this when we interpret the data. Now, the census, as you'll be aware, is self-reported. And so when individuals were responding about their illness, they may have chosen for a variety of reasons to disclose or not disclose different medical conditions. We also need to consider that different groups within the population may have had a different response or willingness to disclose their medical conditions. And so when there are comparisons made between different subgroups, this needs to be considered in that interpretation. The surveys also focus particularly around disabilities. So when we're looking at non-communicable diseases, it only gives information on some of that picture. And in the census, if an individual has been in a healthcare facility, whether it's a hospital or a nursing home for more than 6 months, their information won't have been captured in the census. And so we need to consider here that a number of more severe medical illnesses won't have been included in that report. So for this reason, we can interpret the census to find that there are health needs of diabetes, of arthritis, of cataracts, and the others that were mentioned in the report, but this may not reflect the full burden of illness. Additionally, we don't know that these are the leading causes of illness, as because this was focused more on disability, it didn't include things such as depression or cancer or cardiovascular disease. So these are things that we need to draw from other sources. Therefore, it's important that we collate together many different sources to have the full picture and have a key emphasis on medical information from healthcare facilities. To that end, we are developing surveillance here in the Cayman Islands for non-communicable diseases, and this includes data on hypertension, diabetes, obesity, chronic heart disease, chronic kidney failure, and COPD. This will then be able to give us an idea of what the prevalence of these non-communicable diseases is in the population and which groups are most at risk, and we can then target our prevention measures and interventions accordingly to this data. Currently, this is focused on data from patients who receive care at HSA, and in the future we look to expand this to be able to give national coverage from this data. As has been explained by the Minister, prevention is a key aspect of public health. We're looking to be able to prevent the disease, and to do that we need to understand what the risk factors for those diseases are and try to reduce the prevalence of the risk factors in the population. Some of you may remember the STEP survey that CMO mentioned in her presentation that was done 10 years ago here in 2012. This remains one of the key sources of information in the Cayman Islands on the prevalence of risk factors for non-communicable diseases. It has a number of behavioural risk factors that data is gathered on, so this includes tobacco use, as has been mentioned, alcohol use, physical activity or inactivity, and diet. And it also includes a number of biological risk factors, for example, obesity, raised blood pressure, or raised blood glucose. We're looking to repeat the survey in 2023, and this will enable us to have a much more up-to-date understanding of the prevalence of these risk factors in the population so that we can know how best to target our interventions going forwards. And it will also enable us to look at how those prevalences have changed over the last 10 years. I hope that some of these insights of what we're working on at the moment have shown you the public health significance and importance that we place in understanding the epidemiology of non-communicable diseases here in the Cayman Islands. It's a top priority for us to evidence both the burden of the non-communicable diseases, but also the risk factors and the prevalence of those to inform our public health action. And this is the start of our efforts to develop and strengthen public health surveillance here in Cayman for us to be able to protect and improve health and wellness of the population.
Thank you.
Thank you very much, Ms. Corbett. I will now open the floor to the media for questions.
Good morning, everybody.
Good morning.
I have quite a few questions, so if somebody wants to jump in or interrupt me, feel free. I was curious, can you explain a bit more about the public health situation if it's being taken off from the HSA side of things? What will that mean on a practical level?
Where we are right now, it's still, as I stated, in the business case phase. What is envisioned for it, we will actually have a bigger briefing on that when certain elements right now are actually reached or come to head. But we were able to identify that the separation based on the composition and how it's made up right now, with HSA being a statutory authority as a competing healthcare provider and public health, the separation was obvious from day one that it needed to actually happen. And what it entails and how we move forward and develop is hinging on this business case.
I mean, will it have an impact on staffing, on infrastructure?
It will, but that
we have
will
a
all
public health building?
Yeah, all of that is actually into the whole picture as to why it was important for us to get a business case that would even have an idea of the map and what staff, the amount of staffing, job creations, how it's managed. We're still finalizing that part, and we will be more than happy to share those details as it develops once that time is right.
Okay. And the decision behind, or the background behind that decision, I mean, did COVID highlight that public health needed to be an entirely different department? What was that the impetus for it?
Earlier on, from the day that I've taken office, and COVID highlighting certain issues, but just looking at where we are internationally, that was a huge driving factor that we had to look at public health. This isn't something that just came up in 2021. This was actually embarked on from as far back as 2008. I stand to be correct. We have reports that actually supported that. And COVID has highlighted and created a lot of silver linings in where we could improve public health and healthcare services, even access to healthcare workers. It has highlighted a lot of things, but this is one that was on my forefront, definitely at the beginning, knowing that we had to make a change with the current makeup and separation thereof of public health.
Dr. Newton, do you agree with this decision? Do you think public health should be an entirely different offshoot?
So I'm really glad you asked these questions, because this is not something which is unique to Cayman. Okay, before I came here as interim CMO, I was the head of a program that the Public Health England has. Public Health is a public health program to support the UCOTs in the Caribbean across the world. And then obviously I was in the UK when the pandemic time, etc. So the lesson learned during the pandemic are being learned all over the world, because there is no country, even the most sophisticated country with the most sophisticated public health system, which has had an impeccable response to the pandemic. The issue here is trying to understand what went well, and we keep it, and we strengthen it, and what went wrong. And the key message which is coming out, and as I said, that's not just Cayman, that's everywhere, is public health needs to be strong, independent, and, able to collect information which is countrywide and needs to be provided then to the policymakers so that the right decision can be made. Because we can't risk what we have risked in this pandemic. And in looking at the international press, there is almost every day now, you get, we got cases of a type of Ebola in West Africa, then, we should have never seen two cases together, etc. So we know that the risks of international threats are enormous. And we need to be really strong and prepared, and public health needs to lead, etc. This is why it has to be, in a place where you can look at the whole of the Cayman and be strongly independent and be accessing information not just from the public sector, but also from the private sector. That's what Rachel was mentioning, because we have the issue of the communicable disease, and then we have the issues of the non-communicable disease. If you try to ask us now, but how many people have got diabetes in the Cayman? Well, we can't answer. That's the simple question. So the reality is this. This, of course, I've been working all my life to strengthen public health in many, many countries. And I'm absolutely delighted that the government here is so keen in doing that. And this is going to benefit the aim, the objective there is very, very clear. We need to have a system which has got the right information, which then can give the right indication to the policymakers. That's what we are trying to do, because it's about the health and well-being of the population. That's our job.
Yeah. Thank you for that. As a follow-up to that, actually, we've seen the cancer registry has been around for many years now, but even they say the statistics on that are not absolutely accurate, because there's no incentive. Well, maybe not incentive, but the private sector doesn't necessarily have to report every single case of cancer, and I'm assuming we're going to have the same issue across every other illness and condition that we're talking about here, be it diabetes or anything else. Are we going to see a situation so that we get more accurate data, whereby the private sector is almost obliged to have each one of these conditions as a reportable disease?
Okay, I think this is quite a complex things, that you have also to, what you do in this situation, you also look at other countries, what is already working there. But let me reassure the people immediately. When we talk information for public health, it is anonymized information. So there is no patient identifiers, clearly, because that's not Big Brother. So what you're going to do is to develop a subset of data that then you ask all the providers to provide. And that's what is going to give you the possibility of start analyzing, start to understand, etc. Are there more people who have got diabetes in Georgetown or in proportion? Or in another district, what's going on here? If I don't know, I can't act. That's what Rachel was saying, You do surveillance for action, not for the sake of wanting to know. And the information in public health is always collected and shared on the basis of the need to know. So if I'm going into infectious diseases, I do need to have the public health team, the surveillance team, needs to have the name of the individual, because there are actions that can be done to stop the spreading. That's different from when you talk in the non-communicable diseases. So if there is a need for legislation to support and to say, all the health providers have to give to this central unit, this Department of Public Health, this subset of information. If we need legislation, we will have to look into that. But for the time, in general, if you look at all other countries, you see that there is legislation which is mandatory for the communicable diseases, because that the risk is immediate and you have to stop things, etc. So laboratories or clinicians, they have to report anything which is positive within a specific list of diseases. For the non-communicable disease, we'll have to look at the legislation, etc. But again, let me reassure, this is a subset of data which have no patients identified, because that's no use to us at all.
Sure. Thank you. On communicable diseases, any new cases of dengue? We had one case so far. So any update on that?
Just one.
Just the one so far. Okay. The Moderna booster, I know you said it's coming in with the next batch of Pfizer. Any date on that? Do we know when it's
Not
arriving?
yet. I've sent emails, so I'm still waiting to. It's a complex. I know, I know my poor colleagues in the UK what they go through. So it's extremely complicated because it's it's in the warehouse that they have to supply the whole of the UK plus the UCOTS. So this is why it takes a bit of time. They will be responding pretty soon, I'm sure.
Thank you. This might be one for the Minister or perhaps for the Chief Officer. We saw the judicial review result on the health city concessions and on sort of qualifications for institutional listed medical staff. During that case, we said that a review of the institutions that were given that criteria would be carried out. We haven't really heard any more information about what that entails. Are you able to speak to that at all?
You want to take it?
Okay. So, thank you. So we've just received a judgment recently. We've not gone through all of the details of what other actions, proactive actions might mean for going forward with the issues that were identified and contested. With respect to concessions, we would not be able to speak specifically to that. Obviously, Ministry of Finance would be more suited in that respect. With regards to institutional registration, it's something that we've been looking at from time I think Minister entered office for sure, and how do we ensure that we have that balanced playing field and balanced level for all providers. And saying that because those are the comments that you get and that it's not balanced, so I'm using that very specifically. How do we ensure that all providers are aware of what is actually required from the various types of registration? And of course, anything that needs to be strengthened in that regard, then we have to look at that. We've received recommendations from our Health Practice Commission with respect to various instances of registration that we are currently considering as well. So there is some work ongoing even before the judgment came forth. So we're not yet in a position to say what that might look like, but that is happening currently.
Okay, so we'll look out for that when it comes.
Okay, sure.
So I'll do one more question and then I'll sit down. Can we get an update on the mental health facility?
Okay, that's good. The last update that we had, and it was presented to actually Cabinet, we're looking at the facility itself coming to completion by the end of this year, understanding that there were supply chain shortages that just slowed everything down. But I can assure you that the facility in itself is is beautiful from what we've seen. We're planning a tour in the coming weeks, and we are eager and we're aiming possibly at the end of this year to actually have that up and running based on what we're seeing. But the biggest delay, because we wanted to get it done by the end of first quarter, but because of supply chain issues, that's really what has held that up. But so far, what we're looking at the end of this year, and that is going to be huge for mental health and getting our people home. And we're hoping to have them home for the holidays.
Thank you very much.
Thank you.
All right. April, would you like to come next?
Thank you, everyone. I'm just looking for a little bit of clarification, just to make sure I understand. So we talked about the business case in terms of the separation. Did we mention a time frame for that? Kind of where are we in that process?
Timeline for the business case and.
Yeah. So we're looking at a 6-month timeline right now. That would be the, I think, most conservative time period. We obviously have some work ongoing as is happening, and we'll have some updates to Cabinet within that time, and possibly by the beginning of December for sure.
If I can just add on a little bit onto chief officers, this is the first time that an exercise of this magnitude has taken place. And that's why it's important that the necessary checks and balances are done, and understanding that lives and operation of services for HSA, that those partnerships continue, and that it is clear that it's not done in any silos, or it was not a unilateral decision from a ministry's perspective. And that is why it's imperative that we make sure that we work with the right set of people to get it right.
And I know you've touched, Dr. Newton has some, you have as well, but I'm kind of looking for a high-level summary of the why. The implication is that it needs to occur because it didn't work the way that it did. That's what it sounds like. So I just want to clarify, why do we need to do this, at this stage?
Okay, sure. You can expound a little bit
so,
more, Doc.
There is no implication on that sense at all. The colleagues in public health, they did an excellent job in a very difficult situation. I would say all the situation I know of, Cayman has done particularly well, actually, compared to other places. The issue is that you have your public health team sitting within a provider. And so the collection of information there is limited to the population which access that service. What we need for public health to work, you have to have it outside all providers and getting the information from everybody. So that's the main reason. There are obviously a lot of other nuances and things, etc., which I'm not going to go into now because, as I say, we're trying to develop the business case. Is a very complex but well-established procedure. We have to go through, etc. So, and there will be regular update to explain and work with the partners to say this is why, this is the evidence for this and the evidence for that. But if you look around in the world, everywhere, public health works at its best when it's independent. Mm-hmm. So being within a provider is very, very difficult in that sense, not because they have not been effective by all means, no. It's not that. It's because it's how much you manage to cover the whole of the country. Yeah. Mm. Okay? If I get the information only from the people who have got diabetes and they go to HSA, and what about the others that don't go to HSA? I know nothing. Mm-hmm. So how can I say then, let me advise on how to readjust the service so that I can target that particular problem?
I think that explains it well. Mm-hmm. So with the new CMO coming. What's next for you?
For me, I don't know, knitting.
Knitting.
Not very good at it.
And this last one is for you, Minister Turner. Just, a lot of announcements today, so a lot of change, a lot lies ahead, but you have a short window, in some respects, potentially, in which to do that. What are the priorities for you as Health and Wellness Minister to get done before we start to run into election season, which will be here before we know it?
Definitely see the separation of public health and definitely get on the way, because that is something that will impact greatly on our jurisdiction. Advance and improve the whole tobacco legislation, the pharmacy legislation, and even if it is to begin on reviewing the national policy, health policy for the Cayman Islands. I have all faith in the team that we've been working with so far, with my ministerial team. We're building that from the time I've taken office. I realized where the shortfalls were, and I say this a lot of times to my chief officer. I will go in there and I look at her and I'm like, how do you do it? How did you do it? Because if you're seeing all of the announcements that we're making here today, from just having our in-house communications person to having that epidemiologist at a national level, building out our policy team, that what looked almost impossible to achieve without having additional resources is actually possible now. But in priority, it is definitely this public health separation, because I don't feel this is the last of communicable diseases that as a jurisdiction and globally that we will have to face, is making sure that we are ready as a nation. We have the resources and the skill sets that is there for us to make more informed decision, and for us in my political position to make policies and legislation to drive the health and safety of our nation. And I feel confident that we will be able to meet at least those four things mentioned within the limited time that I have remaining.
Thank you very much. I appreciate it. Thank you.
All right, I'll now call Cayman News Service to come forward if you have any questions.
Morning, everybody.
Good morning.
Just very briefly, the new CMO that's coming from the UK, were there any local applications for that job?
No.
No, we did not have any.
Okay, just wanted to check that. The public health issue, obviously some of the things that other countries have been wrestling with is looking at the tax codes, and especially for us here it would be duty. So it has even before you do the separation, this is something as a ministry you could look at. Have you considered looking at reducing taxes on healthy things that we have, like, because we have duty on some odd things? I think, as I pointed out once, that lard's duty free, but like olive oil is 27% or something. Mm-hmm. So, things like that, and also the introduction of a sugar tax is quite popular in Europe. So, are those the things that you've given any consideration to?
And the immediate form, I will not answer you and say yes, but I know that this approach and how we approach this public health and awareness, understanding that tariffs and duty concessions, decreasing of products, comes squarely on CBC, and that's Finance, Minister of Finance. We are, in this whole exercise and approach in the wellness arm of our nation, is working and is willing to work with other ministries, as this is crossing a number of fronts. So that is something definitely, Wendy, that we could collectively look at as ministry to ministry and lessening the duties on so forth on certain products. We have actually started with the diapers for older persons,
right,
and even the formula for baby feminine hygiene products. So expanding that along, tying in with the wellness arm, I see no problem with it. But specifically for health, I'm quite sure they will get the support.
And if I may, Wendy, thank you very much for your question, especially on the sugar tax. Again, this comes from my experience as the director of the Public Health England program for the UCOTS. We have the example of Bermuda amongst the UCOTS in the Caribbean, which has introduced the sugar tax. And they have done also quite a lot of work to evaluate its impact. So this is always precious, because then you have something which is very comparable. Cayman and Bermuda are roughly the same population, sort of income available, etc. So this is definitely one thing we can look at. But as Minister said, is a multi-ministerial job and approach. And as we have been talking so far, we do need information, we do need surveillance, and we do need to have a very strong public health department, because that's then one of the things where you can get into.
Yeah, I see that. I see, because you have the crossover with Ministry of Finance is quite a few areas, because another area, and I think it's not your fault because of the circumstances with COVID, but we've never really heard as a minister what your policy position is or what your political belief is with regards to health insurance cover. We've heard Mr. Sanders speak about it a lot, and because it is in his thing, but at the end of the day, it's also very much important to you, because if people can't access health, it doesn't matter how great a delivery system you have. So, I mean, what's your feeling about the key issues? So first and foremost, a national health insurance cover for the country that would either be through Cineco or whatever, or do you want to see us provide free healthcare for older people and children and leave those in the middle for themselves, to fend for themselves? What's your, Miss Sabrina Turner, Minister of Health's policy position on health insurance cover?
Well, I think, Wendy, and thank you for this opportunity, and finally asking where me, as the Minister of Health, ask and stand on these things. And I can assure you that with the regulatory falling directly under the remit, and a lot of calls come to myself personally, or the ministry, of being able to access Cineco in order to tap into the services offered by HSA, we have gotten a number of concerns for that. And again, cross-ministry works. Insurance, yes, Cineco falls directly under the Deputy Premier, Finance, and accessing, going through the NAU process, the Honourable Andre Ebanks. So that's including health and wellness. That's 3 separate ministries. Personally, where we stand in it, we have to look at it from the regulatory point. I would support making sure that the access to health care is fair and balanced to everybody in the country, and that is why we work hard where ministry budgets is concerned and what line items is given to HSA for indigents and for HEA2, which we grapple with annually because we can see the need for those services, and accessing it is key, but also making sure that we have the buy-in from my colleagues around the table that we are actually buying a service that we're getting value for as well, but also preventative care. People being fair of not having insurance, not going to get checked out, and showing up when it's almost at the end because they didn't have health insurance. So where I stand on getting access to or supporting a national health insurance, I support it, but making sure that we look 360 at the implications. There is nothing where giving and offering free health care to our children or even our retired persons, but we have to look at the end of the day that these bills and offering of health care comes with a cost. If we can off-balance that, and it's fair and balanced, that no one is felt as though they're any less by trying to access health care, that is a primary aim. And I do support it, but it has to be collectively, and we have to look at it 360, because the cost of healthcare globally, no different in the Cayman Islands, is not decreasing. But I feel we can deal with this approach by adding the wellness arm and getting access to and educating our people of the wellness arm, even of their insurance coverage. A lot of people don't even understand that there's a wellness arm of preventative care that's in their health insurance, if they have it. And I think we need to expound on that and educate our nation a bit more. But supportive, yes, you have me on board 100%, but it has to be done with the necessary regulatory framework, and we have to know that the funding will be given to it, that we can definitely stand on our own 2 feet at the end of the day.
Thank you. just one question, because it came up today because HSA did put out a statement about it. I understand that the situation with the ambulances, because the Health City does have a fully equipped accident and emergency. I don't think people realise that, but the statement that was released today is still a little confusing. Why don't we just have a simple case of wherever the accident is, the ambulance goes to the nearest A&E? So if the accident's in Bodden Town, then the ambulance goes to Health City. If it's in West Bay, then the ambulance goes to Georgetown. Why have we not got that a clear cut thing? Because there's no difference now between the standard of the HCCI A&E and the HSA A&E.
You want to speak?
Yeah. Okay. Yeah, Wendy. It sounds very simplistic when we say it that way, that it can just go with whichever location. But I think there's a bit more involved in that, and we have to make sure that if we're redirecting an ambulance or services elsewhere, that entity is equipped to be able to attend to it. I won't pretend to know all the details involved with respect to when an ambulance is diverted elsewhere or is on call. That would be more for our colleagues at the HSA that would be able to speak to those specific details. However, we at a ministry level always look at how best we can improve. Are there other providers out there who are able to support that sort of emergency situation? And so those assessments are ongoing as to the extent of which we can say then that, we can comfortably divert an ambulance somewhere else and know then that the level of care is exactly what we would expect under emergency conditions. Because you have to make sure then that entity is operating a 24/7.
The obvious question has to be is, why don't we know that? I mean, it's been there for ages, and obviously it does take, HCCI does take emergencies on occasion. So, and they have been able to treat them, and often an ambulance will go past Health City all the way to Georgetown, only to be sent back again to Health City almost immediately. It just seems, why haven't we joined this all up yet? What's been the delay? What's the problem?
Understood.
Yeah. I'll ask our colleagues who are present to speak with respect to the HSA ambulances and what those procedures are, and then maybe that will shed more light.
Ms.
That, what you're.
That was my last question. So
okay.
Thank you very much.
All right.
All right. I will invite Ms. Lizette Yearwood from the Health Services Authority to come speak to that question.
Thank you much, Wendy, for that question. I just want to reassure the public that the HSA has a fully operational emergency room, and over the years we have been the only provider of emergency services. However, we have worked very closely with the other providers to make sure that any gaps in services that are identified are addressed. And again, I just want to reassure the public that HSA's EMS service is activated by 911, and when the EMS responds to an emergency, they assess, they treat, and they transport. And in so doing, they are in constant communication with the physicians in the emergency room. And the process that's in place now is that there are emergencies such as cardiovascular emergencies that are diverted directly to Health City, but this is done in a very collaborative way. So communication has to be engaged right from the scene, where the EMS staff communicate with emergency control at the emergency room, and then communication has to be had with Health City to ensure that they're ready and available to accept that emergency when it arrives. And like Minister and Chief Officer said, this is something that is being looked at to see if there can be, to see what other services are available, and if there's any changes that can be implemented. Thank you.
All right. With the interest of time, are there any other remaining questions from media? I'll take about 4 more. 2 more. And please, respondents, try to keep your answers as concise as possible.
Good morning, everybody. I just want to ask you a quick question about the impacts of the tobacco legislation and how that will impact us once it's been adopted under the new framework?
Well, that we will get some more steer also from the committee. So yeah.
Okay, so this cabinet asking for the extension
The treaty.
is because we are already there. So basically, to be able to ask for the extension, you have to fill in this table, which shows that your local legislation has already been amended to accommodate the framework requirements. So everything which is, so Cabinet wouldn't have been able to ask for the extension if the work had not already been done.
There's no more that needs to be done or changed.
No, I haven't said that. So this is the first step. And basically is, as I say, things like we have the legislation that says you can't smoke in public buildings, on transport. Have you got a system to support people who want to quit smoking? Are you doing advertising campaigns to say that? Are you put on your package the health warnings? So all these things are already in place because the 2008 was a legislation on tobacco was readjusted. What is the taxation you put on tobacco? Are you selling cigarettes individually rather than in a package? Do you check the age of people who buy? So all that is done. So now the table will be assessed by the FCDO colleagues and Department of Health and Social Care in the UK, and they will say, yes, that's right. Then there is additional legislation that you can introduce, which is to do with the graphics on the package and all the elements. And this is then up to us to see whether we want to go that other step forward and so on. The whole point is reduce prevalence of smoking and support people who want to quit smoking.
Okay, excellent. Second question really quickly. Minister, you spoke a lot about some of the results from the NDC survey, and I just wondered if you wanted to give a really brief overview of perhaps some of the initiatives that you might be thinking about implementing to deal with those issues.
Definitely more awareness with the NDC and understanding that that is still preliminary, and we were just the importance. And the main reason I pulled out those stats is to tie in with why it was important from a national level to have an epidemiologist in-house, collection of data, and the importance of data in order to help policymakers and the ministry to drive initiatives, as you were alluding to. So based on that data, we can now prepare programs working with NDC, and there may be other ministries and other SAGCs to actually deal with these issues in collaboration with education as well. This could be far-reaching, even in the homes with our young parents. So the whole idea of prematurely providing that information was to just tie it in to why it was important to have at a national level an epidemiologist to collate the data, to collect it, understand it, in order to develop programs.
Okay, lovely. Thank you very much.
Are there any remaining questions?
Good morning.
Morning.
I have a quick question for Dr. Newton. When you talk about the extension of the framework towards the Cayman Islands, I was curious, do you have any particular view whether the use of tobacco is more dangerous than the use of cannabis?
The use of?
Cannabis?
I don't have to answer this question, I will have to prepare a bit better. And so, because it's, you have to review all your literature. It's not only me giving you my personal position. I will have to look at the evidence to give you a more correct answer, more precise answer.
Thank you. And one question for the minister. Are there any plans to make cannabis available for recreational use in the future?
That would be a collective policy decision in combination with, as the CMO alluded to, the data as a government and see where that is. It is topical. It has been making the rounds, and more information as a government, a policy, and the people will actually help us make that decision. But we're ministry alone in this particular fight. This is far-reaching, and we would love a collective response from the entire government, how that aligns, and definitely, most importantly, what we feel in regards to that subject matter as a nation as a whole.
Okay, so you might foresee a referendum on the issue then?
That is all, again, a means and ways of getting a temperature and a feel of what the people feel, and if that's what it is, the public will be informed at their appropriate time.
Thank you. One last question. The chief officer mentioned the recent judgment, and in that judgment it referred to encouraging the government, encouraging cabinet to publish the criteria for concessions. Is there a timeline for publication of that criteria?
Mm-hmm. Okay, so thank you for your question, but unfortunately I would not be able to answer that. Concessions do not fall under the Ministry of Health, so I would not be able to speak to whether there are any plans in place or any timelines with respect to that. From a Ministry of Health standpoint, we published our criteria with respect to the institutional registration, and that was the aspect in that case for us. But I will not be able to speak on concessions. That's outside our remit.
Thank you.
Thank you.
Thank you, and that brings our State of Health and Wellness Media Breakfast to a close. Remember, you can always replay this event on the Cayman Islands Government YouTube page. For more information on all government news, visit gov.ky. I'm Takia Smith, and it's been a pleasure to be your host today. Special thank you to our panelists and our media for being here with us. Thank you, and have a good day.